Uh, Perfect. I was going to say, is this being recorded? So like you said, I'm a first year. My name's Nate. One of the first years at Doctors Hospital Orthopedic Surgery Residency in Columbus, Ohio. Uh, I went to med school at OUHCOM, kind of have that picture down there in the bottom left. I went to the Dublin campus. Had a great time. I'm now 7 months into my residency here and just thriving in the ICU unit. We do like 6 away rotations, so um, it's part of the process. But so just a little bit about my program here, real quick, since you all are here, and I think it's a pretty awesome program. We take 5 residents a year, obviously 5 year program. Mostly involved working at a level 1 trauma at Grant Hospital in downtown Columbus. And we're not there. We're usually at Riverside for a lot of our elective things, but we'll also do trauma there as well. It's a very busy tertiary center. Um, Talks about that. Fortunately, unfortunately, becoming like a level 1 hospital. So that's just shows how busy it is there. It gets kind of crazy too. So a lot of good experiences there. And then obviously Nationwide Children's is in our backyard. So incredible opportunity that we have to work there. Doctors Hospital is the flagship program, a flagship hospital. It's just a small community hospital outside the city, which is really good to get some community experience as well. So it's awesome. We're all within the Columbus metro area, which I think is a great place to be, a great place to live and work. So without further ado, this is a little bit of an outline, x-rays, some resources, auditions, prep, and advice. So I don't know how familiar everyone is or what years and all this and that, but x-ray reading is basically is like ground, like floor zero, level 1. Like this is something that you need to have down. Whether if you're first year, start taking a look at it. Second year, maybe become more familiar, but definitely by third year level, being comfortable at least with the flow. So just kind of talk about it. Uh, there's kind of a formula to going through, like when you're presenting these and when you're going to be asked about them on auditions and when you're just thinking about them or calling your attending overnight. So you want to start with, what are we looking at? Like start super basic. So what modality? Is this an X-ray? Is this a CT? Is this an MRI? What body part? Right upper extremity, left upper extremity, right hip, left hip. Simple. Views, AP, lateral, oblique, mortise, stuff like that. And then skeletally mature, immature. If you look here, I put like this example photo in. Can you see my mouse when I do this or no?
Yeah,
Pete?
we can see it. Yeah.
Okay, sick. So obviously immature here because the device is still opened. But so that's something to make note. And then laterality, is this a right arm, right hand, left hand. And then you actually get into your fracture reading. So what bone is it? What bone is broken? Is it the humerus, radius, ulna? Where on the bone? The proximal third, middle third, distal third. Uh, Fracture pattern. I have a slide. Next slide kind of talks about fracture patterns. And then displacement's pretty important too. Um, so we can talk about that on the other side as well. And then I have like a little RADS mnemonic that I think was helpful when I was a med student. So rotation, apex, displacement again, if you already forgot displacement there, shortening. Couple points, and then degenerative changes, lesion mass, and soft tissue. This stuff is like more not as high yield. Like I want to be calling that out all the time unless there is something glaring or maybe a lipohemorrhosis that you'd see on a CT, something it's just not as high yield. Like if you get through this first half and then maybe touch on one of these RADs, I think you're doing pretty good. And it keeps it a lot more simple and short and sweet. Um, Something of note. So when we talk about angulation is always based off the most distal aspect of the bone, right? So this is angulated volarly. This side's volar. This is dorsal. So volar, dorsal. So it would be in volar angulation. And if you guys have ever heard the term apex, apex is literally just the opposite because it's referring to the proximal part of the lesion. So this is apex dorsal angulated volarly. Hopefully that makes sense. I'm going to try to talk about super simple things that maybe you guys already know, and it's like, what the heck, but I don't know, just trying to cover my bases. Fracture patterns, definitely be familiar with transverse, linear, oblique, whatever, oblique displaced, spiral, which some people say spiral fractures meets criteria when it's like twice the length of the bone or twice the length of the fracture. Or you'll hear if the fracture lines are parallel with the axis of the bone. It's kind of confusing, but by and large, just recognizing that it's more of a rotational twisting mechanism of force that causes that than others, than like an oblique. And then comminuted. This green stick is more when it comes to like pediatric stuff. We don't need to talk about it. Displaced, pretty obvious. Shortened, obvious. Angulation, I kind of touched on that, and rotation kind of speaks for itself as well. Sometimes people say translated. Displaced and translated are almost synonymous. I guess translated is just moving in like this, like coronal plane, whereas displaced is kind of a catch-all for it being moved in multiple planes or any other plane. It's just easier just to say displaced and keep it simple. So here's like a little example. So I'll kind of read this one out loud, and then we'll just kind of run through a couple ones. People can ask questions, and I think I have some probing questions after that too, just to kind of clue you in on other things that are important. So yeah, so here we have two views. What are we looking at? So going through views, two views, AP. This is, I guess, supposed to be kind of a lateral of what? Left hip, left femur. I guess left femur film. This person's skeletally mature. So now we get into fracture. So where it's a mid shaft, what bone is it? It's the femur. Fracture pattern, it's oblique. So you can say a mid shaft femur fracture. It looks oblique in orientation with approximately 50% of displacement. Minimal angulation. I wouldn't even comment on angulation really for this one. And then you could get into length of arm and rotation. You could say it's shortened, which is kind of important, kind of not. Rotation, it's kind of hard to tell on this because we don't have the full view, but you would assume that probably be internally rotated based on just where the fracture is. And then obviously no degenerative lesions or masses. So sounds super simple, but at the end of the day, I think I wrote it down here too. Maybe it didn't save, but you want to have a one-liner to help it sound smooth. So, I say I got two views of the left femur in a skeletally mature individual demonstrating a short oblique mid-shaft femur fracture with minimal shortening, and you just keep it at that. That kind of paints the picture super simple. So we'll just kind of go through. If anyone wants to kind of read these, go ahead and unmute your mic. We'll kind of go from there. And you don't have to worry about sounding dumb or not knowing, like, I don't know if we have 1s, 2s, 3s on here. Or I can just pick some.
Yeah, I'm a first year, so bear with me.
No, this is good. What's your name? Yeah. Who's this?
Ashley.
All right, sick. What
so
you got, Ashley?
We have two views, AP and lateral of the right shoulder.
Yep.
Skeletally mature, with displacement of the humeral.
Demonstrating. Maybe tell me what's fractured before you even.
Humeral head.
Yeah.
Okay.
Definitely proximal. So we could say like a proximal humerus fracture.
Okay, proximal humerus fracture, displaced, proximal.
Yeah. So in this scenario, I would more say if you look on this lateral, you could say more. This is anterior and posterior. So I'd say like anterior displacement would sound more would be more correct.
Okay, sounds good. I was really looking at that AP, so I need to
Yeah,
not focus so much on one and use the second one
yeah,
as yeah.
yeah, and it's shortened as well. So like I don't think you're wrong, but just when we talk about these, you'll kind of hear the lingo more. But that's really good. Like you could say, kind of put that all together: two views, AP, scapula Y lateral of a right shoulder demonstrating a proximal humerus fracture, and involves the surgical neck. Right, because we could go into it more, but different parts of your, different parts of the proximal humerus fracture is something that would be good to look into. But no, that's great. Um, and you mentioned skeletal immaturity. That's just a good thing to kind of get into the rhythm over time. So two things before I get distracted. Let's keep going. If I showed you this, would you want to get maybe any other views or just something? I guess actually, it's kind of I read my mind, kind of not. If you just saw these X-rays, would you want to get any other X-rays? Does the one, I guess, on the right look a little concerning,
Uh,
given its displacement?
Yeah, the displacement, possibly you want one of this more like the scapula?
Uh, Not as much. And this is kind of that's good thinking. There's also something called like an axillary view. So it's important to get these. So this is when it's on the right. It's important to get these. Basically, you have the patient lifting up their arm like this and shooting an X-ray into it. Obviously, their arm's not this high. Uh, Sometimes this is painful. I mean, it's always painful, and so they don't tolerate it as well. So you can get something over here, which is called the Velpel view. And the reason that you get either of these views is to see if the glenohumeral joint is reduced. That's the main thing. Because if it's dislocated, we may need to reduce it. So this is a different fracture that we had come in the other day. Just a quick picture of it, just to kind of demonstrate that. Like sometimes you don't appreciate a dislocation on an AP film, and they may even ask that in like a med school exam. I feel like I might have gotten asked that, or maybe not. I might get it confused, but that's always just kind of a good. You'll see over the time as you study orthopedics, there's a lot of things that you'll see that you should almost be like, see this, think that. Like I don't even know the equivalent to medicine anymore. Like yeah, I don't even know. Like BUN I don't even know why I'm saying this. BUN creatinine ratio of like 20 or something. Think, oh, they're dehydrated. Like it's kind of like that. Like proximal humerus fracture looks kind of funny. Let's get an axillary review. So that's just the only point I wanted to bring up with that. But that was really good. All right, who wants to knock out this one? You could even figure out which side it is already. It's halfway done. Anybody?
I'll chime in on it. My name's Jeremy. I'm a
Yeah.
third year from LeCom. Um,
Sick.
so we have three views of a left wrist here. We have AP, oblique, and then lateral. In a
Mm-hmm.
skeletally mature individual, it shows a distal radius fracture that appears to be intra-articular. Um, yeah.
That's. I think that's perfect. Uh, Jeremy, right? Yeah, great job. Uh, Oftentimes keeping it simple will keep you out of trouble. And letting me or another resident or someone ask you questions based off of that, like if I was like, hey, do you think it's angulated or this or that, then you can answer. But I love how you just kept it all the high yield stuff. Something I wanted to make mention of was exactly that. Anytime you're around the joint, saying it's intra or extra articular, I think is really good, which you did. So whether this be like a tibial plateau or a distal femur, um, distal humerus, like anytime distal radius, obviously, it's key to know if it's interarticular or not. With a distal radius, just remember this in the future. If you're unsure, there's probably a pretty good chance that it's interarticular. Um, here, like another kind of important question I think to go along with that is like understanding. So you have your AP oblique lateral. Like what makes a good, Jeremy, I know, a good lateral view of your wrist? And if you don't know, that's totally fine.
Yeah, I was gonna say I don't really know. I mean, I'm assuming it's relation of like one bone to another, but I don't really know.
Yeah, yeah, exactly. You're thinking the right way. And sorry, I don't mean to put you on the spot, but uh, so what we always say is you want to see the radius lined up with your lunate, which is like this teacup looking bone, and then on top with your capitate. So these should all make a straight line. So that kind of makes a good lateral, and a good PA or AP view is where you have minimal overlap of these metacarpal bases. And then you can see Galula's lines really well. So what you can here. So I'll show some resources that kind of, maybe should have touched on this earlier, but easiest way to start is like looking at normal, understanding normal. You know, it's really hard to tell. I definitely kind of went against my own advice with this, and like already it's so easy. Like, I mean, it's a lot less boring to look at like fractures and like try to read stuff like that than looking at normal x-rays. But obviously very important to know what normal is, to know what's not normal, and to know what a normal should look like. What's a good radiograph? Because oftentimes you'll get bad x-rays and it's like, okay, can I trust this? Can I not trust this? Especially intraoperatively, it's important to know what your true views are. So yeah, good job with that. And again, as we go through, any questions, feel free to ask. I think, do we have one more after this? No, we have two more. So real quick, anyone want to try to knock out this one? Before I call somebody, just to keep it moving. JD, my man, just because I see you lurking.
All right, we have
JD, where are you from?
I'm a third year from PCOM.
Oh, nice.
We have three views of the hip. We have an AP and a lateral of the hip, a right AP of the hip, and then a lateral of the right hip as well. Then a skeletally mature individual displaying a right femoral head fracture.
Yeah. So yeah, let's start from the top. Good job. I like how you started going down. Kind of, this one's a little bit different because this guy up here, so this is an AP pelvis. So you have an AP pelvis, and then like you said, an AP and lateral of the right hip. So I think that was really good. And a skeletally mature individual demonstrating, you can kind of see here, right here, what side is this? The right side. So a right femoral neck fracture. So this would be more a femoral neck than like a femoral head. Well, you can get femoral head, but yeah, this is something that you see quite commonly. So it's kind of a good example. And I kind of had this prompt up here too. Does anyone, I guess, like, again, this is just the reflexive thinking. Like, I think it's good to know. So I don't want this to be like a pimping session, but anyone, like, how have you seen these treated at all, or have any idea of how these are fixed?
Maybe you want to get a traction view,
Yeah, yeah, I think a traction view could be helpful
maybe
to
a
help
CT.
better. Yeah, yeah, both of those are good ideas. I don't think you'd be faulted for not getting a CT or a traction view in this case, because the fracture pattern, it seems pretty like clear, like you see it pretty well. But if the patient's being a jerk to you or whatever, and you feel like they deserve a traction view, then you can give them a little tug. Just kidding, I'm not endorsing that. But it can be helpful to delineate the fracture pattern sometimes, especially when it's comminuted. And you could save on the CT. So it's a good thought. And then my other thought is another point I wanted to touch on was anytime you get a fracture of a joint or a long bone, you always want to get imaging. This is just a general rule, joint above, joint below the fracture. So we have a proximal femur, or excuse me, a femoral neck. I see most of the femur, but you always want to be able to get like a distal femur radiograph as well, because it's like, let's say you get that and it's like, oh, you want it for this patient, but if it was like an IT fracture and you wanted to do a long nail, you for sure would want to get full length films to see if there's anything distally. And if you ran into this distally, you definitely want to know about it before you're in the operating room putting a nail down this guy's leg. And that's a catastrophe kind of thing. Not a catastrophe, but not a pleasant surprise if you saw that. So some other things that you want to start thinking about: classification. So like people love the Garden classification. I think if you haven't studied anything orthopedics, I think doing hip fractures and kind of going through that first, understanding the Garden classification, kind of, and whatever the PAL classification as well, how these initially are treated in the ED, which really isn't much of anything, but fix or replace them essentially is what it comes down to. So I think that's like a good first place to start. We're not going to go into it tonight, but just kind of get your mind rolling. And then last one, can I have anyone? Thanks for doing that, JD. That was great.
Of course, thank you.
Anyone else? If not, we can keep moving.
I can take this one. I'm Dan. I'm from PCOM. 3.5 between on a research here right now.
Nice.
Here we have X-ray, 3 views of a right ankle, AP lateral and oblique, demonstrating a lateral malleolar fracture.
Yep.
Yeah, I don't see
Lateral
any,
malleolar. Yeah.
and no
Say it
posterior mal. I don't see any other mals involved, so just the lateral malleolar fracture and the skeletal immature individual.
Yep. Yeah, that's great. What would you say? How would you describe the fracture on this one? The fracture pattern?
Oblique.
Yeah, I think it definitely looks
Or-
oblique. It looks a little comminuted to me too, actually. See multiple fracture lines there too, but by and large, a major oblique piece. Any other views that you think you'd want to get with I would probably say a distal fibular fracture. Lateral mal wasn't wrong. I mean, kind of synonymous, but that's just the way I feel like I would, I don't know, say it. I guess I shouldn't correct you. Either way is fine.
Here I probably get a tib fib view, knee and then foot.
I like the idea of getting proximal. Maybe there's a proximal fracture, proximal fibular fracture. But maybe foot, I don't think is really necessary unless you thought there's pain. What about involving the ankle? If you had an isolated distal fibular fracture, those could be treated honestly non-operatively. This one, I don't think you'd be wrong to say, hey, let's try to put this in a walking boot. What would make it operative? Do you know?
It was displaced, but I don't know the limits. I'm
Yeah, that's
assuming
okay.
a certain amount of millimeters of displacement. I'm gonna guess 4, just because that sounds like a good number.
It is a good number. You're kind of right. So yeah, basically it's you're testing, so you're going to do your stress view, whether it be a gravity stress or external rotation stress view. You want to see if that medial clear space is going to gap, which is an indication of syndesmotic instability, which would be a surgical indication for us. So but yeah, 4 millimeters of clear space is your cutoff there. So I don't know if that's where you got the 4 from or not, but that's typically what we look at. So always something that's another one of those reflex things. Like, I don't know, you see strep, whatever it is, and gosh, I hate ICU so much. It's ruining me. Like strep bovis or whatever it is, and then think colorectal cancer. That's what this is. Isolated distal fibular fracture. Think, I gotta get a stress view. This might be a bimal equivalent. So that's what we'd call this, a bimalleolar equivalent. The reason being, the syndesmosis isn't intact, so it's behaving like a bimal fracture essentially. I guess if you want to be technical, you're technically stressing the deltoid ligament here, and that's why this is gapping. So you have an unstable ankle that needs to be fixed. Does that make sense?
Yes. Could you explain how they get a stress view? What's like
Yeah.
the position?
So basically, So this right here, this view this is a mortise view. You said oblique, which isn't wrong. So basically, you do this view, except so you start off with that, which is like 15 degrees of internal rotation of your leg, and then you can even see a hand here. Grab the leg and stress it in like a valgus external rotation force, and you're basically trying to gap this medial mal, this medial clear space. So you literally are holding their leg, and then you got your X-ray there in the ED, and because they don't like to do this a lot, at least at some hospitals, so you have to be the one to do it. Or you have them do a gravity stress view where you hang basically, if you think of it, you hang their leg off the end of the bed or whatever it is, and just have it gravity do the stress view that way. That way you don't got to go down there and do it yourself sometimes. Just kind of depends. You got to play the game. So, yeah. Good question. That makes sense?
Yeah, perfect sense. Thank you.
Yeah. Ankles are another good one kind of to start on. As far as studying. So basically, that's it. That's all I had for fracture reading. Super basic, not really in depth. But I just the biggest thing is kind of getting your one-liners down of how many views, what am I looking at, and just getting it to sound fluid, just like anything when you're presenting a patient or anything like that. It's, less is more. Say it with confidence. Definitely take your time and read it so you can say it with confidence. But if you're able to get a smooth kind of template out for yourself and do this, you're already going to sound a lot better than literally 50% of the students you rotate with. So definitely a skill that I maybe didn't work as hard on. Like, I really cranked it up right before my 4th year auditions. Just saying it out loud. Like, oftentimes I just see it in my head and be like, oh, I know what this is, but actually say it out loud to yourself and like get used to like saying these things in a flow. So other half of this talk is pretty much what I wish, or not what I wish, because I had some great mentors along the way, but I wish I would have had like a clear outline of resources to follow. Orthopedics is like just one of those areas where it's not really touched on in med school. Very minimal. I mean, my anatomy lab was during COVID, so like I had very little exposure to anatomy. We did prosections. Like, it's just not talked about as much, and it's kind of a smaller community. So I kind of just wanted to share on here like what I used and was super helpful for me. I like to think I did well in my auditions and knew some stuff. So I kind of just wanted to put a template out there for you guys to take and be like, hey, I'll go here. Like, this is where I start. Like, this is my boards and beyond and pathoma and sketchy outline, for getting through med school. So for getting into orthopedic residency. So if you haven't heard of Pocket Pimps, I'm sure you have. That's a great resource, and it's definitely something I recommend investing in, because even if people, residents, especially in my program, know what's in Pocket Pimps. One of the authors is a graduate from our program, so while we may intentionally not ask questions from it, it still has a ton of great questions in it, just because it's so high yield and important to know, especially the anatomy section. So if you don't have Pocket Pimps, get Pocket Pimps. And with that, Pocket Pimp also has short, high yield videos online that you can watch that are super, I think, helpful to get into when you're first starting. I talked about what makes a good X-ray. I think they have good videos on what makes a good X-ray of different parts of the body. So what I did is I would make an Anki deck over that, or maybe there's one floating around, I don't know, or take notes or kind of go along the way. So certainly Pocket Pimp is great. The other thing I will say though with that is I would run into, and you'll run into this too, where students just memorize like a random fact. It's like stating like the cutoff for diabetes is 7 or 6.5 or whatever it is. Like it's like out of context and like it's great. Oh, you know that, but it's like, what does it mean? So let that kind of guide your learning. Like if you read something in there and it's like, oh, the surgical indication for this is, 2 millimeters a step off, or what's this fracture pattern? And if you know an eponym or you memorize an eponym, it's like, well, why is that important? I don't know. Go look it up. Like there's more, like go the extra step to show that like you are learning. And a good place to do that is literally typing in online, or like ortho bullets too is like the next thing that I think would be helpful to do. So Pocket Pimp is great. Ortho bullets. The way that I would use ortho bullets as a student is to basically, if you haven't been on the website, create an account, go to the high yield topics for each subsection. So there's like trauma, sports, recon, hand. Go to those high yield topics, and basically everything that's listed as it's ranked from like A, B, C, D. If you were to go through all of those topics, except for maybe peds and like pathology, and you knew the A topics pretty well, I think you'd be pretty dang near ready for an audition rotation. So focusing on the blue highlights, because that's obviously what we focus on, and focusing on, there's little question marks if you haven't been on the website, I'm sure you guys have, but focusing on those as well, like those points are obviously like what we used to study. And the way I always thought of it was like, if residents are using this, then I'm going to focus on what the residents are focusing on, because that's what they're going to ask me questions about. Like, may seem all smart and high and mighty sometimes, but honestly, sometimes it's like, I don't know, I read this last night, or I was preparing for this for whatever thing. And yeah, that happened to me multiple times. I'd get asked a question by a resident. I'd be like, I know that's an ortho bullets question. That's like why you know that, or I don't know, that's why it's on your mind or whatever. So just think smarter, not harder. Those two resources alone are great. I think Dr. Nabil Ibrahim, like I have this little photo up here. He has goofy videos, or I think he's from Toledo. Awesome videos. Like if you have any topic, I think you could start like proximal humerus fractures, type in proximal humerus fractures, Nabil Ibrahim, and start with his video. And then from there, you can go into your Pocket Pimps or into your ortho bullets and read on it more. Just really high yield and really good imaging. I'm definitely a visual learner, so like that was like a great overview. Student to stud. I meant to call this out earlier. They literally have a video. You probably could have skipped my whole lecture and just watched this video on how to read an X-ray. So sorry for wasting your time. But they have other great videos similar to Nabil Ibrahim, just not as many. That again, this is a graduate of our program now, Brian Skura, did when he was in residency with us, and extremely helpful. I'll mention it later as well. They have another video I think that's great before auditions. So definitely do these videos, definitely do student to stud, definitely do hip and knee book for your joints. So arthroplasty, hips and knees, it's great. Quick, easy reads, good diagrams to help explain what you need to be looking for, and things to know. A lot of pimp questions kind of come out of that too. So definitely that's like an online ebook that you can get for free. If you just type in hip and knee book, it comes up. Yeah, right here. Miller's Anatomy. People always talked about Miller's and like having that, and I don't know, you should buy it, and people would walk around with it. I honestly didn't use it a ton. Just use whatever anatomy resource like is helpful for you, and like you can navigate well, understand. By and large, Miller's is great, but there's certainly other great resources too. I think everyone should have the AO Surgery Reference app. That's something that you could definitely use to study approaches. Super easy to understand. So that's what I recommend for anatomy. And then OTA lecture slides are really helpful. You just type that in online. This guy, OrthoClips, another YouTube account, literally talks over a lot of the previous series. So, or he talks over the slides and kind of explains stuff. So if you're like a visual guy or you just want to listen to it in the car, that's great to play. And then another thing great to play in the car, the Nailed It Ortho podcast, OTA podcast, Ortho Bullets podcast. Nailed It Ortho is probably the best just because it's a little bit more conversational, entertaining. These guys are great. if you're struggling with any topic, they probably have a topic over that you can listen to while driving into work or whatever it may be. So honestly, these are the resources that I used. You'll every now and then I type in online like a question or blah 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 that you have to look up, but by and large, like use this, let this guide you, and I think you're pretty set for third and fourth year. So God bless. This is just for me. If you have a third year audition or a third year rotation, hopefully you do. Sometimes you just can't get them, but I definitely would encourage you to do that, whether it be at a home site or somewhere else. But my goal by my third year rotation, so before I started it, I had all of Pocket Pit memorized. I had gone through those top 15 sections I had talked about in ortho bullets. If I didn't have a letter of rec, I was, really trying to get one from whatever attending that was there, or if you guys had been doing that previously, that's great. And then also trying to get on like any research projects. This is really something you should be doing as first year or second year, even too. And then the biggest thing third year is while you're definitely trying to prepare your resume and look good and get your foot in the door in a couple places, step 2 scores are obviously incredibly important too. So making sure you're taking care of, that's almost like the baseline. I always thought was I need X step 2 score to even kind of get my foot in the door. So if you guys, I just tried to break it down there by third year, fourth year. And then finally, how much time do we have left? About like 20 minutes. So leave some time for questions. Audition advice. Some of you guys are third years. Before third year is over, do your research, especially right around now. I know applications start opening for, or if they don't, early spring they do for audition rotations in the fall. Some programs use vSLO, some others don't. So make sure you look that up. I highly recommend making like an Excel sheet or something that you can keep them all in the same place. If you have buddies, make a shared Google Doc. That way you're helping each other out. I know it's a lot of extra work. Make sure you're checking boxes with your school, making sure that you're doing things right there, because sometimes I love my school, but my former med school is always tough to some schools have limits on how many rotations you can do and X, Y, and Z. It's crazy. And then do your best to find out if you actually think you'd be a good fit at a program. There's people know people. Orthopedics is a small world. So whether you're talking to current residents, shadowing, doing research, or just by word of mouth of other previous med students that maybe they were older with you and matched at a program, like keeping those contacts and kind of reaching out, showing genuine interest goes a long way. All right. Any questions then? Because the next 2 slides I have are related to when you're on your audition rotation. So as a fourth year. I just need a break from talking too. I don't usually talk this much. All right. Keep this short and sweet. So on your auditions, general principles: first to arrive, last to leave. Work hard, don't complain. I think that makes sense. It's just very much sometimes it's just a grind. And I feel like that's by and large a lot of the places you go, especially in orthopedics, is that kind of personality of put your head down, get your work done, don't complain. But we're going to have fun doing it and be team players and embrace the suck sometimes that comes with long days, hard days. So as a student, make sure you're the first to arrive, last to leave. That's something I always did in my auditions, and I like to think people noticed, even if they didn't. I was never late. I never seemed lazy, and I was always there for anything interesting or to make myself the best. What do they say? The best ability is availability. So if something was coming in, someone came into the trauma bay towards the end of the day, or somehow I was lurking around, then I was able to be there and have that experience. So work hard, obviously don't complain. Another thing that we talk about sometimes is being too comfortable. So just know that people are watching with you, be respectful, don't swear. It's something that being too buddy or broy with somebody, it's just remember that there is a little bit of a power dynamic at play. And just to kind of respect that, I think is important. And the second part of that was you're always under a microscope. So, you know, it's kind of stressful, and it's kind of the worst part of auditions, but like just realizing from when you even start pulling into like the proximity of the hospital, who knows, you could be behind a nurse or something. So don't be tailgating somebody. Like, it's crazy. Like, it gets to that level of detail, but people talk, and you're just always supposed to be on, you know, always only be on your best behavior. It's kind of simple, and you should be doing it anyways, but just a reminder. Sometimes there's long days and you can be super stressed, and sometimes you run into nurses or other staff that aren't super nice, and sometimes you just got to take it on the chin. So just be kind to everybody, no matter how you may be treated. Certainly not at our program, but other places I rotate in, that could be the case. So another thing that I think is huge: be a good teammate. You're definitely competing against these other people. It's a weird dynamic. Like, you're with other auditioners, you guys are all gunning for the same spot, but so you're competing against each other, but at the same time you want to show that you're able to work with each other, and that you're a good teammate and an enjoyable person to be around. So it's like this weird balance of like, I want you to do well, but I want to do better than you, kind of thing. It's almost like I played baseball, so it was always like someone else is pitching on the mound. Like, I'm definitely rooting for that guy on the mound, but I'm definitely ready and grinding, and I'm going to be ready to go. If bases get loaded or I need to go in there, like, I'm going to be ready to get in there and relieve and get us out of the jam. So it's like, you kind of have to have that mindset, and it's kind of hard, but we definitely look for that, especially in our program. Like, sometimes we could ask a question of like, interviews, be like, hey, who did you really enjoy rotating with here? Or who would you enjoy being co-residents with here? You know, as a testament to, are you being a good teammate, or are you going behind people's backs, saying things that aren't true, taking other people's cases, intentionally doing something or not helping somebody to make them look bad, those kind of things. And then another really important thing, and this is really annoying too, because I hated this as a student, but being helpful and being present, but not being in the way. So if you're trying to help out in OR or trying to help out in the ED, sometimes there's a time to speak, and a time to joke, and a time to help, and then times to step back, be invisible almost, or like, don't get in the way, don't ruin the flow of things. So it's kind of hard to read the room in that sense, but it's a little bit of like social awareness. So that kind of goes a long way too. So that's kind of some general principles to live by. Some more physical examples: definitely prep for cases the night before. If you miss a question or you get pimped, read up on it for the next day. Go and find that resident and tell them what you read about whatever topic you missed. Seems goofy, but it's showing that you take initiative and that you're trying to learn, and that like you're not just taking an L and moving on. Definitely, so this is where I say be proactive and helpful. So if you know how to, and Pocket Pimp has good videos on this, or any other, honestly, if you just any video, how to set up like an AO splint or sugar tong splint. I would highly encourage you just make a notes tab in your phone or something like that you can reference. That maybe you're in the case with a resident, or maybe you're just shadowing the case and they get a consult for something in the ED, that you could run down to the ED and get everything set up for them, get the hematoma block material stuff ready for them. So that way you're making the intern's life way easier. They're going to notice it. I would certainly love it. Pull the imaging up in the room, so everything's ready to rock and roll. That's like a great example of being proactive and helpful. And again, hindsight, you got to know how to do these things too. So don't try to help in and help maybe position a patient in the OR if you're not 100% sure, or if you're not really sure how something should go, because then it could be awkward and you kind of get in the way and you kind of don't know what you look like you're doing. So it's okay not to know. Watch it, observe it a couple times. Then when you feel like you know, like the next step or whatever, hop in there. So knowing how to suture and hand tie, I think you should be competent, at least simple interrupted, horizontal mattress, and know how to do sub-Q suturing. And then definitely tying spelled wrong there. 1 to 2 hand tying, 1 and 2 hand tying. Those are skills I feel like baseline that you should know how to do, as well as, again, putting on the splint, the materials for a splint. That's like bread and butter orthopedics. Like, We want you to know how to do that, or at least have the idea of it day one. And then when you're on Audition, ask questions about the program, show genuine interest in the area, what the program's like, because you could be living here the next 5 years and people want to know that. So we obviously want you to want to be a part of the program. And a couple don'ts: don't be annoying, don't make excuses. Nobody likes that. Don't ever, I wish this is like one of those hidden rules, little nuggets. Even if you know the answer to a PIMP question, let's say you're with an intern like myself, and I goof up on the question and you know the answer, and the attending asks you, you don't know the answer. All right, you do not know the answer. If I don't know it, you don't know it. It's just a thing. It's annoying. You want to show that you know, but I promise you it goes a long way. Me personally, I would not care. But at other places that I've rotated, and it's kind of a general rule, don't try to make your resident look bad or one up your resident. Now, if it's another med student, it's a different story. But that's just kind of an unsung rule sometimes. Some places, yeah, I'll just leave it at that. And then again, last thing is like, it's just attitude. Don't be overly bossy, overly competitive. If I'm asking Peter a question, Dan, don't just chime in and be like, oh, it's this. Like, no, I wasn't talking to you. I was talking to Peter. Or if it's just kind of a feel thing. Again, like, don't ask questions that you already know the answer to, but you can ask questions that show that you maybe I know the answer to this, but how does that relate to XYZ? Like, that's like a smarter way to frame it, you know? Be like, oh, I think that we're gonna do like a posterior stabilizing type implant for this knee. How do you think, like, how does that affect his under knee, or how does that affect what we're gonna do? Do you think that that's what we're gonna do? Or like, even like just framing it in a sense of like not being like, oh, Nate, what's the treatment for this hip fracture? And then you want me to ask you, I don't know, what is it? And then you'll be like, oh, it's a hip arthroplasty. Like, it's something, this is dumb, but I've seen it done before. It was aggravating as a student. It's even more aggravating being on the other side. So yeah. Does anyone, that's kind of all I have. Questions, I know it was a lot. Be happy to answer them. This is definitely your guys' time as third years. You're not expected to know stuff.